So I'll be introducing, it is my honor to introduce our next speaker. We fondly call him Sir Charlie. Back when I was still an emergency medicine resident, he was our consultant in the UPPGH. He had chaired the Committee on EMS and Disaster Management of the Philippine College of Emergency Medicine for several terms. So currently, he is Chair and Assistant Professor 7 of the Department of Health Policies and Administration in the College of Public Health, the University of the Philippines, Manila, where he is also overall Disaster Risk Reduction and Management Committee Chair. He is member of the University of the Philippines System Crisis Management Committee, an advanced trauma life support course instructor of the Philippine College of Surgeons, medical director of the TransCare Emergency Medical Services, disaster preparedness and management coordinator of Medical Center Manila, and core group member of the Philippine Academic Society for Climate and Disaster Resilience. To speak on the Emergo Training System for training disaster preparedness, I was also once a student here. Let us all warmly welcome Dr. Carlos Primero Gundran. Sir Charlie, the virtual floor is yours.
Yes, thank you, Pauline, for that very kind introduction. Can you allow me to share my screen? I cannot share my slides.
You're allowed already.
Okay.
Charlie.
Yes, it's done. So thank you very much. So I think I can begin now with my talk. So the title is the Emergo Training System, Training in Disasters. So for my disclosures, the material presented in this talk is based on the Emergo Training System owned by Region Östergötland, a regional governmental healthcare provider in Sweden. And competence in the Emergo Training System is administered at the Catastrophic Medicine Centrum, the Center for Research and Training in Disaster Medicine and Traumatology. And this is in Linköping, Sweden. So for my objectives, one is to introduce what the Emergo Training System is for you, and number two, to enumerate its application in trauma management in the setting of mass casualty incidents and disasters, like in triage, treating, and transferring patients from the site, and possibly testing your existing trauma systems theoretically for from the scene to the hospital. So what is the Emergo Training System? It is a simulation system used for education and training in emergency and disaster management, as you can see in the picture on the right. It can test and evaluate your incident command system, disaster preparedness, the effects on the medical management system, and the resilience within your organization. So these are the things that you can test and evaluate by using the Emergo Training System. And it uses magnetic symbols attached to magnetic whiteboards to illustrate and make visual representations of a disaster scene or an assembly point of a hospital. Excuse me. Now, the training materials are as follows. So the core of the Emergo Training System is a victim bank with injured patients divided into categories depending on the severity of injuries sustained. So they have about, I think, 500 cases to choose for. The instructor in an exercise can choose suitable patients for a particular scenario. And on this right side, we can see the magnetic patient symbol. Maps, different frames and models and pictures are also included in the material to help construct the scenario to make a visual representation to the participants, to make the simulation more realistic to the players. So we have these patients, and in the patients, details were validated for these cases, and developed alongside experts in the field, such as the National Burn Center in Sweden and Western Australia, and the Catastrophic Medicine Centrum, Center in Disaster Medicine and Traumatology. So these are the patients, and you can see the victim ID, and you can see in front is the observable information, the one that you can narrate or explain to the participants, and behind these cards are the vital informations which would help in the management of these patients, but the participants have to ask you for the specific information. So not information is given, like for example, the facilitator will not tell you that the patient has Cushing's triad or something, or Brick's triad, Beck's triad. You would have to ask that to the facilitator yourself, or you have to do a physical exam. You have to search for something if you want to know the answer. So it will not be given automatically. Now, there are also management cards pertaining to each specific patient or victim. So this corresponds to victim number 401, and it contains the basic information. It contains existing medical conditions of the patient. It contains the primary survey findings, as you can see, airway, breathing, circulation, disability, and exposure, and the time of arrival of the patient in the sequence. So this is what the patient will present. This management cards is more on the ER. And at the back of the management card, you can still see the victim ID. You can see the necessary procedure that needs to be performed in the patient in order for the patient to improve or deteriorate. And you can see the possible outcome. Like this one, it is color black, so the patient will die eventually. But most of the management cards, the patient will improve or deteriorate. It depends if you did the critical tasks that is required. Now for the staff, we have the sample staff. This one on the left side, the middle and the left side of the map are the staffs found in the Philippines. No, the fireman uniform, the police uniform, the Special Police Officer, the Department of Health Emergency Management Bureau, the Search and Rescue uniform, the military, the barangay captain, no? And on the right side, you can see the general sample avatars, which can be found in Emergo in general. No? So if you purchase them, they will actually personalize your sample staff. They also have sample vehicles, police vehicles, helicopters, fire trucks, ambulances, and other vehicles, no, for patient extrication or patient transport. And other magnetic symbols like hospital buildings, vehicular crashes, fires, medical buildings, and trees and others, no, to make the scenario more realistic and believable for your participants. So once you combine all your magnetic avatars, you can actually build the scenario. For example, this one, a plane crash in a supermarket, and you have the victims, the different patients sprawled across the area, and you have the arriving responders. No, you have the medical team, you have the rescuers, no? And you have the I think this is our what do you call this? People who are not supposed to be there. So this is a sample scenario. So this is what we are using in the disaster simulation training in the UP Manila DRMH Center. So we use the Emergo Training System to create a scenario and test the resource management and the medical treating skills of the participants. So for example, this is again your incident site, and you have a vehicular crash. I think two buses, a bus and a train collided with each other, and you have multiple victims around the area. And as an arriving medical team, no, what you need to do is you have to triage each patient. So you can see the yellow tag, these patients are triage yellow. The green tag, these patients are triage green. And these are the available pre-hospital staff and the ambulances, and these are the search and rescue team, and these are other patients needing further evaluation of the triage officer. So you want to see how mass casualty incident is managed in the site, no? In how the incident command system is applied and executed, not just patient treating skills. So this is an example of an incident site wherein the patients are already sorted according to priorities, green, red, and yellow. I think this is a building fire because the drawing here shows a building, and here are the firefighters surrounding the building. There is also an incident command post wherein the incident command team discusses and manages the situation. Like for example, this one, a plane crash, and this is North City, this is small town hospital, this is Westfield, advanced medical post, and so on and so forth. So you have an incident command post in which the incident command team plays around and makes their decision. No? And you can see them how they perform in the specific scenario. And this is one example of an incident command post with the incident command team discussing how they will face or manage the situation. And part of the incident command post, you have the logistics or staging area, wherein the logistics officer will account for the arriving responders that wants to help in the situation, the ambulance, the police, no? And their arrival time, and how you will distribute these available resources later on as they are being called or needed by the operations officer. And this is the operations. No? And here, the operations officer must account and take note of how the available resources faces the demand of the situation. Like for example, you have multiple casualties, and then you have, of course, you have your medical staff, and then how these medical staff, are they qualified to treat the corresponding patients given to them. So this is the job of the operations officer. Make sure that everything is being addressed and accounted for. And of course, we have the first aid post in the field. And as you can see, the first aid post, there is patients, and again, the triage tag of the patients and the available resources, and later on the disposition, where will this patient be, will they be brought to the hospital, or will they be brought to the, what do you call this, the green area, or will they be managed? So you can see here the triage, the first aid post, and if any management is applied, so like for example, you can see an IV fluid here. No? Sometimes you can see an intubation, like oxygen done. No? So you give proper management, and then you decide if the patient will be sent to the hospital or anything, depending on your disposition. Waiting for transport, red waiting for transport. So you have priorities for patients that will be transported to hospitals. And this is how the field team manages mass casualty incidents. There is a facilitator who watches them and assesses them. And it's a very challenging part actually for first aiders, actually, medics, paramedics, and even doctors. No? They find this part challenging and exciting because you have to assess, and then you have to manage your ABCs. And if you miss a critical task in managing your ABCs, your patient will actually deteriorate, no? And could possibly die. Now, there's also a hospital setting, and this is a setting for a primary hospital. And you can see lots of patients arriving, and you can see the staff of the hospital, the available staff that needs to see these patients in the different rooms. No? So the manager in the small, like for example, this one, primary hospital, a small town hospital, is now beginning to triage and distribute the arriving patients to the appropriate doctors that should see them. For the secondary hospital, like for this one, the ED, it has a more advanced staff, like for example, it has emergency physicians. No? So it's the same. You have to distribute the arriving patients according to the care they need and according to the expertise of your available staff. And you have to manage your patient properly. And if you mismanage your patient, of course, the patient has a tendency to die or deteriorate. So this is Johan, one of our facilitators. When we trained in Emergo Training System, he is explaining what happened in this scenario. Now, for tertiary setting, for tertiary hospital setting, it also shows you how you will distribute your patient after the ER or after going to the OR. how will your post-operative patients be accommodated? Can they be accommodated in your available ICU beds and the available staff, or any other wards like neuro, chest surgery, or burn unit? So you have to distribute your multiple casualties appropriately so that they could be accommodated properly. And it's a challenge in distributing your resources, distributing the patients according to the available resources. So you have your doctors, you have your nurses, and you have to, and they have limitations, no? Like for example, one doctor can only focus on one critical care patient, something like that. No, it depends on your, the rules that you will establish in conducting your simulation. And patient dispositions. No? So it could be in the field, it could be in the ER, it could be in the primary, secondary, or tertiary hospitals. No? You could actually choose to discharge the patient. You could actually admit the patient. You could actually pronounce the patient dead. No? So you need to make dispositions on the mass casualty patients that arrived at your institution and document them properly for further evaluation. Like for example, this one. What is the disposition of the patients that has been arriving? Will you transfer them? Will you admit them? Or will you manage the airway first before you transfer them? Everything is done in real time. No? So the exercises involve real time, or sometimes if the event is a prolonged event, you can actually speed up the time. Like for example, 1 minute is equivalent to 5 minutes. So that's it. No? So for prolonged incidents. You can also have a hazmat scenario, no? A hospital hazmat scenario, or a field hazmat scenario. You have decontamination showers. No? So all arriving patients, you have to decontaminate them first and so on. If decontamination is not done, then your whole ER staff will be contaminated and possibly become patients also. It depends. No? So you can do different scenarios, like for example, this one, building fire, and for example, this one, a plane crash incident. And what is most valuable in these simulation exercises is the hot debrief. No? So you analyze what transpired, you analyze if the patient survived, you inform the participants what they did right and what they did wrong so that they could learn and improve and not repeat the same mistakes again. So this is what is valuable actually in these exercises. So the Emergo Training System helps the participants by visualizing the current status of the incident to better allow them to make accurate decisions and perform their tasks. And by using magnetic symbols to represent patients, resources, and staff, we are able to simulate actual factors that affect the arrival, transport of the mentioned elements such as time delay and traffic. You can actually add, depends on your imagination. The expert-validated victims ensure that participants assigned in the first aid, advanced medical posts, and hospitals receive patients with accurate injuries and conditions to manage and treat. So there are specific critical tasks that could be performed in each patient, no? Because they are validated. They're not just there without any reason. So there is a way to, if you do the right thing, they will survive. And if you do the wrong thing, they will die. They will also be better tested in managing and requesting limited resources during trainings. So resource management in disasters and managing available resources. The skill or competency of each participant in treating acutely injured victims can be assessed depending on the skill competency of the facilitator. Now, for first aiders, you can actually test them on their level. No? But for nurses or doctors, you can actually elevate the skill. And like, for example, this one, no? Having a trauma surgeon facilitating the ER scene, you can actually test if the ER physician can accurately or appropriately manage a trauma victim requiring advanced management. So you can increase the skill level of your assessment for the participants depending on the skill competency that you want them to accomplish or to complete. and sample scenarios. No? So we can do hazmat decontamination scenarios besides the multiple trauma. And we can also do military setting or war mass casualty incident with penetrating injuries and others and blasts. No? And other scenarios. No? So it depends on your imagination. No? You can actually improvise as long as it is realistic. And I think that is my last slide. Thank you very much. I think I would like to return the floor, the virtual floor, back to Dr. Convocar.
Thank you very much, Sir Charlie. But let us immediately proceed to the reaction. And kindly hold on, and we will entertain questions a bit later. So to proceed immediately to give his valued reaction to the talk of Dr. Gundran, let us welcome our next esteemed resource person, Dr. Teddy Wardhana, who is a consultant orthopedic and trauma surgeon of the Airlangga University of Soitomo Academic General Hospital in Surabaya, Indonesia. Apart from this, he is also an orthopedic consultant in several other hospitals, including Siloam Hospital and Mayapada Hospital, a hand, upper limb, and microsurgery consultant in Dr. Sotomo General Hospital. He is also a trainer of the Indonesian Advanced Trauma Life Support and the reviewer of the scientific publication Joints or Journal of Orthopedic and Traumatology Surabaya. Dr. Wardhana, sir, the virtual floor is yours.
Hello, good evening. Thank you, Pauline. It is a very interesting and very informative presentation by Dr. Carlos Gundran. Yes, I think I'm agree with Dr. Carlos. So the training system like ETS is very important for us, especially for the country like Indonesia. We have a lot of natural disaster like earthquake, tsunami, eruption, and almost every month we have a natural disaster. And if we have the same point of view from each of the medical centers, so it is will be easier for us to handle the disaster, because sometimes I have some experience in tsunami in Aceh, earthquakes in Yogyakarta, Palu, and also in Chengdu, China. Each of the disaster have a different condition. Even the casualties are similar, but the condition is different. We need the same point of view, not just from the medical team, but also from other team like army, like fire department, like even the infrastructure department. Because sometimes when we come to the disaster area, every team have a different point of view. So everybody want to be a commander. So we don't know who is the commander now. So it just make us difficult to handle the trauma disaster effectively. And also sometimes when we come to the disaster area, there is no human resource there, because mostly the medical team also become a victim, or the family become of the victim. So the people from the outset coming as a new person don't know how about the facility in there. And then if we have the same point of view, the same way to handle the trauma, especially in the disaster, is it very helpful for us? I also have maybe Dr. Carlos can answer later. Is it the system is personalized, or we can improvise depend on the characteristic of the each place? For instance, for Philippines maybe different with the Indonesia or with the Malaysia or the other place. So what kind of data that we have to collect to validate and to improve the system to make it more suitable for our area? And then also sometimes, like I said, that when we come to the area, the team is coming from the different places. Or for instance, like when we in Aceh tsunami, there is a medical team from Indonesia, from abroad. There is a lot of medical team there, and then a lot of supporting teams. How we can do the effectively to synchronize all this one is together, so we can make a good system to handle disaster, especially for the natural disaster, because for the natural disaster we cannot predict what will be happen. This is a mass casualty and a need early response for the team. I think that's one that I can respond to the Dr. Carlos Gundran presentation, and then this is very good system, and then I think maybe I will learn it, and then we can apply to our country the ETS system. Thank you, Dr. Gundran.
Thank you, Dr. Teddy. Should I answer the questions? I think you gave me 2 questions, right?
Please
Yeah, yeah.
proceed. Yeah.
Okay. So the first question is, how do you validate cases in our area in Asia? Because these cases were the cases were for Europe, I think for Western
Yes,
countries. Actually, I think ETS is open to work with us. No? They actually are interested in having typhoon related cases and tsunami related cases. No? So maybe like they work with Australia and other countries. Maybe we could give them also real cases that they could also use in their to expand their victim bank. No? So that's one answer for the first. Can we validate it in our area? But actually, the available cases, we just use the available cases and form a scenario around the available cases that is reasonable to do that. No? But if you want to create scenarios that are unique to Asia, no? So you have to actually create your own patient bank for that. No? But it's actually better to work together with ETS and improve their victim bank. No? Now, for the second one, you said that we have to synchronize together in times of disaster. Yes, I agree. And that is actually the role of drills and exercises, so that we will be familiar with how each and every one of us should move in a crisis or an incident. And if we practice it, we do it, we drill it together, we will be more familiar and we will be more synchronized and more faster in playing or fighting this game of disaster management. No? Like for example, in a football team, if players play for a championship without practicing together, no, there is no synchronization or coordination. That's why we have to do drills and practice together so that we could be more synchronized. No, sir. I think that's my answer. Thank you.
Thank you, Dr. Carlos. In your experience in Philippines, did you apply this kind of the system to all the primary medical center?
Actually, yes, we are actually doing simulations for hospitals, and actually we also use these simulations for universities. Actually, so we actually kind of evolved it to cater also to university personnel and not just for medical responders now.
Okay, thank you for the information. It's very clear from you, Dr. Carlos, and I hope we all can follow your system. It can be better. Thank you. Thank you. I think